Now we go on to the third presentation from China on neoadjuvant transcatheter arterial chemoembolization and combined with systemic chemotherapy for treatment of clear cell sarcoma of the kidney by Minju Li.
Good morning. My topic is neoadjuvant transcatheter arterial chemoembolization and the systemic chemotherapy for treatment of children with clear cell sarcoma of the kidney. Clear cell sarcoma of the kidney is a rare type of pediatric malignant and renal tumor. It is known as an aggressive tumor with poor prognosis. The aim of the study was to evaluate the efficacy of neoadjuvant transcatheter arterial chemoembolization (TACE) combined with systemic chemotherapy for the treatment of the children with CCSK. From 2010 to 2014, 5 patients with unilateral CCSK were treated with preoperative TACE combined with systemic chemotherapy. All of these patients were diagnosed histologically by percutaneous core needle biopsy before treatment. At diagnosis, the main maximal tumor diameter was 11 centimeter. One patient presented with lung metastasis and one with humerus metastasis and bilateral pleural effusion and one with inferior vena cava thrombus. Patients subjected to TACE with the Seldinger method. A catheter was placed into the involved renal artery. Chemoembolization emulsion consists of cisplatin, pyridoxine, vandacin, and normal saline, and iodized oil were infused into the renal artery. Preoperative systemic chemotherapy with vandacin, infosfamide, and etoposide was administered 3 weeks after TACE. Surgical resection carried out 3 weeks after neoadjuvant therapy in 3 patients, and 2 patients underwent 2 cycles of TACE in the venous neoadjuvant therapy. Post-operative received radiotherapy and chemotherapy. Results: no cardiac toxicity, renal insufficiency, or hepatic dysfunction were found in all patients. Grade 3 marrow suppressions developed in 2 patients. In terms of CISD criteria, 3 patients had a partial response. One had stable disease, and one showed progressive disease after neoadjuvant therapy. 4 patients underwent radical nephrectomy after neoadjuvant therapy. Complete surgical removal of the tumor achieved in 3 patients, and one had intraoperative tumor rupture. The surgical stages were stage 3 in 2 patients, stage 2 in 1 patient, and stage 4 in 1 patient. 1 patient didn't underwent surgery and died of progressive metastatic disease. This is a CCSK in a 2-year-old boy. The MRI demonstrated a huge tumor in the left kidney. The core needle biopsy building the clean CCSK, and the immunohistologic showing positive of Valentine. This is the aortogram shows a large lesion in the left kidney with the vesicular severity, and catheterization of the left renal artery, and chemoembolic emulsion was being infused into the left renal artery. The repeated CT scan showed deposits. The deposits of the within the renal tumor. Complete tumor resection achieved after preoperative therapy. This is in a 3-year-old girl with a huge tumor in the left kidney, and this after the deposits within the renal tumor after TACE, and the tumor before the operation is reduced after operative TACE and systemic chemotherapy. Tumor total after the tumor volume is reduced, and complete tumor necrosis in the surgical specimen. This is a 7-year-old boy with CCSK, and the CT showing pleural effusion on the left and the right sides, and the MR images indicate the proximal left humeral bone metastasis. The CT image shows pleural effusion on both sides disappeared after preoperative TACE and systemic chemotherapy. and continue up to the chemotherapy after the operation. MRI indicating the left humerus returned to normal. Conclusion: neoadjuvant transcatheter arterial chemoembolization combined with systemic chemotherapy for the treatment of children with clear cell sarcoma of the kidney is safe and effective. Thank you very much.
Any question? Yes, doctor.
Morning, this is Dr. K. Gupta from New Delhi. Dr. Lai, I enjoyed your paper. I have two brief questions. One, I believe the core biopsy was a true cut biopsy and not a fine needle aspiration cytology that I feel. So that to give a definite diagnosis that it was a renal cell carcinoma and not. But my more important point is that what was the real survival during follow-up with this combined therapy? Am I clear?
I'm sorry.
We all know that the prognosis after renal cell carcinoma, once diagnosed, whether you give clear cell after diagnosis is quite bad, but after this chemotherapy, what was the survival, long-term survival in your series? 7 cases is a big series for this type of tumor in your center.
In the last 5 years, we just have these 5 patients and went to the neoadjuvant arterial and interventional chemotherapy. Four patients were survived until now, and 1 patient has died.
Good, thank you.
Thank you.
What was the systemic chemotherapy that you gave? You said it was TES plus systemic chemotherapy. What was the systemic chemotherapy?
Systemic chemotherapy is a cisplatin, vindesin, ifosfamide, and etoposide.
Yes.
Just a word of caution for using ifosfamide in a nephrectomy patient. We did use once for the peanut of the kidney, the protocol of the etoposide alternating with CVT, and out of the 6 patients, we had renal problem and the renal failure actually in 2 patients. So we have stopped using ifosfamide after nephrectomy.
No, that was just a comment. It was just a comment, not a question. The other point is that there is no clear-cut advantage of using TES in addition to the systemic chemotherapy. We all know that clear cell sarcoma of the kidney has a poor outcome, and when they are large tumors, they do respond. So what is the contribution of the chemoembolization has not been really very clear, but I am not too sure if we all practice that rather than intensifying chemotherapy as an neoadjuvant setting. I think most of us, we use neoadjuvant chemotherapy, more aggressive form than the standard treatment chemotherapy for Wilms tumor, and then try to go for nephrectomy. I think that is the common practice. I don't know whether anyone practices more than that in addition to TESS, and what is the contribution of TESS. But this is worth exploring because of the poorer outcome that we observe in CCST. Thank you, doctor.
Thank you very much.